Dear students, good afternoon. Today we will discuss a very important and dramatic topic of modern medicine. Its topic is pneumonia. First, we will start with definition of pneumonia. According to the national recommendation of Russia Federation Society, pneumonia is acute infective inflammatory disease, preferably caused by bacteria. It affects respiratory part of lung with intra-alveolar exudation and parenchyma alveolar inflammation. By the way, this definition was created before COVID-19 pandemic. That's why now we can see not only bacteria preferable causes of pneumonia in nowadays. Often and practically in most cases, pneumonia now caused by viruses and SARS-CoV-2 viruses. According to this definition, there is no acute pneumonia because pneumonia, bacterial or viruses pneumonia, are often acute process. There are no term of chronic pneumonia because pneumonia, I repeat once more, it's always acute process, but not fused with interstitial idiopathic pneumonia. We will discuss about it in the sixth course. In this idiopathic pneumonia, there are several clinical courses, including acute idiopathic interstitial pneumonia and chronic onset like pulmonary fibrosis, interstitial pulmonary fibrosis, or non-specific pneumonia. But today we discuss only pneumonia which caused by bacteria or viruses. In this slide, you can see the structure of the alveoli of the lung, which happen gas exchange between the air of the alveolar, oxygen and carbon dioxide from the blood circulation. But if we told that obvious parameter of the pneumonia is the intra-alveolar exudation of the inflammatory fluid. When fluid filling this alveolar, it's lead to broken this gas exchange. This lead to tachypnea, dyspnea, and some kinds of acute lung failure in severe stage. By the way, in case of bacterial pneumonia, this process mostly located. In case of virus pneumonia, we can see the diffuse alveolar damage. So, but virus pneumonia have got some differences from the bacterial pneumonia. But in case of virus pneumonia, I told it's mostly diffuse alveolar damage, but often and always, in case of bacterial pneumonia, virus lead to affection of the lung interstitial tissue, especially in this slide you can see the damage of alveoli by SARS-CoV-2 viruses and damage of alveoli, capillary and vessels network surrounded by alveoli lead to endothelial cells dysfunction, damage of endothelial of the vessels. It's lead to linkage of the blood cells into the alveoli, into the interstitial tissue, and it's lead to activation of it's lead to thrombosis, micro and micro thrombosis, vasoconstriction is lead to inflammation. This lead to microvascular and microvascular injury. It's very important since that inflammation in case of virus pneumonia more deeper, and infection in practically all severe cases, lung interstitial. But distribution of pneumonia annually in Russia Federation, 1.5 million people suffering from pneumonia. Mortality up to 3% in young people and middle-aged people without concomitant disease, and up to 30% in severe cases. What about coronavirus pneumonia, virus pneumonia? But now approximately 108,000 people in Russia Federation died from coronavirus infection. And but its mortality approximately 2.3. But in this mortality from all infected people, because approximately 5 billion people were infected by SARS-CoV-2 infection. You should know approximately 80% it's mild on asymptomatic course of coronavirus infection. That's why only 20% patients have got the middle severe, very severe course of pneumonia. That's why mortality in general not huge, but if we are talking about severe course, it's very significant mortality from the coronavirus infection. But we make diagnosis of coronavirus infection, and according the temporary recommendation of Russia Health of Ministry now there are 10 edition of this recommendation, but in the world you can find recommendation of National Institution of the Health, and practically each month these guidelines update. Clinical variant and manifestation of COVID-19 infection, acute respiratory virus infection when affection only upper respiratory tract. Pneumonia without respiratory failure, and pneumonia with acute respiratory failure. It's complicated by acute respiratory distress syndrome, sepsis and septic shock, thrombosis and thromboembolism, often clinical manifestation and course of COVID-19 infection. What about etiology of bacterial infection? It's dependent from where, in what condition this pneumonia started. If you are talking about community-acquired pneumonia, first place obtained pneumococcus, Streptococcus pneumonia, up to 95%. That's why we should know that if we prescribe antibiotics against this infection, this antibiotic should be effective against this pneumococcus. And second place obtained so-called intercellular infection, including chlamydia, legionella, and mycoplasma. And very few percent obtained gram-negative bacteria, including Haemophilus influenza, Escherichia coli, and other Pseudomonas aeruginosa. And in case of pneumonia in immunocompromised host, mostly it's like pneumocystis carinii and fungi, different kinds of fungi. Few words about pathogenesis of pneumonia. First is development of pneumonia is related to mechanism of penetration infection. And secondly, disorders of local protective immune mechanisms of bronchi. How infection can reach to the respiratory parts of the respiratory tract, reach to alveoli. First is micro aspiration. Second, it's inhalation. Hematogenic, it's a mechanism often happen in case of, for example, in case for virus infection. Now discuss one point of view that SARS-CoV-2 viruses reach to a lung from the gastrointestinal tract, because you should know in gastrointestinal tract there are, in epithelial, there are a lot of receptors which help to these viruses penetrate into the epithelial cells and lead to circulation and lymphatic way. And last, direct and adjustment way of dissemination of infection. Disorders which support the broken of protective mechanism, including decrease of cough reflex, aspiration of vomiting masses, damage of mucocellular clearance, decrease of production IgE and IgG, and other humoral components of innate immunity. Disorders of function of macrophage condition of bronchial obstruction, pulmonary edema. But you told that in case of pneumonia, the principal criteria of pneumonia it's the presence of exudation, inflammatory exudate filling the alveoli. But in case of COVID-19 lung damage, we can find diffuse damage to the alveoli, many thrombosis of small vessels of the lung associated with multiple hemorrhage of the alveoli, and so-called SARS-CoV-2 associated endothelitis. Local pulmonary systemic productive destructive thrombovasculitis. In critical course of COVID-19 infection, pathological activation of innate and acquired immunity, especially in Th1 and Th17 types, immunity develops dysregulation of synthesis of pro-inflammatory cytokines, so-called formation of cytokine storms. This manifestation are similar to the course of primary or secondary hemophagocytic lymphohistiocytosis or macrophage activation syndrome. In this slide, you can see the clinical pathology and the immunopathology of COVID-19 infection. I would like to stress that increase of pro-inflammatory cytokines happen in all cases of COVID-19 infection with clinical manifestation. But up to 7 days, the level of pro-inflammatory cytokines significantly diminish and normalize. In the severe course, and we after 7 days of course of infection, we can see the dramatically outbreaks of the pro-inflammatory cytokines, including firstly its interleukin 6, 8, tumor necrosis factor alpha, and other pro-inflammatory cytokines which clinically lead to fever, dry cough, headache, fatigue, dyspnea, myalgia, shortness of breath, nausea, vomiting. And these cytokines lead to multiple organ failure, and clinically we can see the increase of liver enzymes, AST, ALT, lactate dehydrogenase, and increase pro-inflammatory protein like C-reactive protein, ferritin, and often we clinically we can see increase of relatively increase of neutrophil count, but in most cases of COVID-19 infection, leukocytes it's normal and diminished. But we can see the diminish of lymphocytes and monocytes, which migrate into the local site of inflammation. And histopathology, we, in case of acute respiratory distress syndrome, we can see this formation of pneumocytes, hyaline membrane formation, bilateral diffuse alveolar damage, but X-ray, it's ground glass opacity, multiple bilateral subpleural infiltrates, consolidation. In this slide, you can see the lung due to autopsy, lung in patient with COVID-19 infection, and with the morphological signs of interalveolar and interstitial edema, hemorrhage, and hyaline membrane, metaplasia of alveolar epithelial in proliferated stage. It's a late stage of the development of lung damage of the COVID-19 infection. And also alveolar macrophage, so-called siderophage fibrin in the late stage of infection. A few words concerning classification of pneumonia. It's very important. We should answer for a question where pneumonia happened, and that's why this answer for this question you should put for the first place in our diagnosis. According to classification, there are 4 types of pneumonia. Firstly, it's community acquired pneumonia. CAP. It's happening in person who has not recently been hospitalized or up 48 hours after admission to hospital. And why we should put CAP for the first place of pneumonia? Because if you are talking about bacterial pneumonia, it's dependent of causative causative infection lead to pneumonia. Because, for example, in case of CAP pneumonia, it's the first plane obtained pneumococcus. In hospital acquired pneumonia, it's quite different. For example, it's early pneumonia, maybe pneumococcus. In late pneumonia, in gram-negative flora microbes, Escherichia coli, Pseudomonas aeruginosa, and other took first place among causative factors of this late hospital-acquired pneumonia. Hospital-acquired pneumonia happened after 48 hours after admission to hospital, and that's very significant problems for treatment because antibiotic-resistant microbes often lead to these types of pneumonia. And you talked about early nosocomial pneumonia develops during the first 5 days after hospitalization. And for example, less resistant and causative bacteria similar look like community-acquired pneumonia. Late nosocomial pneumonia develops after 6 days of hospitalization, and this higher risk of polyresistant pathogen and less favorable prognosis compared with early nosocomial pneumonia and community-acquired pneumonia. And some kind of hospital-acquired pneumonia, it's ventilator-associated pneumonia. It's a subset of hospital-acquired pneumonia, which occur after at least 48 hours of intubation and mechanical ventilation. By the way, note this 48 count because it's magic count for pneumonia. We will say it about other characteristic of pneumonia and treatment and monitoring for 48 hours or days. It's very important for criteria for pneumonia. That's why hospitals were acquired pneumonia 48 hours of intubation and mechanical ventilation. By the way, before it's not signs of pneumonia before mechanical ventilation or intubation. Aspiration pneumonia is caused by aspiration for an object, which are usually oral gastric contents, either while eating or after reflux of vomiting, which results in bronchopneumonia. Lost protective reflexes allows aspiration of oropharyngeal flora into the lungs. Aspiration is facilitated by altered mental status from intoxication or some narcotic alcohol abuse, and neurological cases, for example, after stroke. And for example, fourth type of pneumonia in immunocompromised hosts. Diagnosis of pneumonia. Gold standards. Firstly, we told pneumonia is acute inflammatory process. That's why acute onset. And our confirmation that this situation is acute onset. It's not, for example, exacerbation of chronic portion. We must be sure. And fever, acute cough What does it mean, the acute cough? Acute cough, it's cough less than 3 weeks. Chronic cough, more than 8 weeks. To new detectable infiltration of the lung tissue, pleural pain due to affection of the parietal pleura, and dyspnea reflecting to disruption of gas exchange. So clinical manifestation including cough with purulent, some kinds of bloody rusty sputum, tachypnoea, shallow breathing, flaring of nasy, occasional cyanosis, limited movement at time of involved sites, for example, in case of involved pleural and pleural pain. Patient is very ill and lie on the affected side to decrease pain. Dullness, so if consolidation is large due to percussion, you can detect due to percussion. Increased fremitus in the presence of consolidation, vocal fremitus. But by the way, in case of pleural effusion, it's in decreased fremitus. Fine crackles or so-called crepitation. By the way, crepitation in different stage of development. Pneumonia may be different. For example, it's early crepitation when start of pneumonia. Then when alveolar filling, the exudate, it's absent of crepitation, any of breathing signs. And after during recovery, during diminish of exudation, it's maybe so-called crepitatio redux. First, it's crepitatio index, then absent, fine crackles, and crepitatio redux. It's after recovery. A variety of crackles with lobar and occasional rhonchitis, maybe moist rails, mostly in case affection of surrounded bronchi. Bronchial breath sound, loss of appetite, low energy, fatigue. And mandatory laboratory instrumental investigation included complete blood count with leukocyte formula in dynamic of treatment in outpatient, in patient setting, and chest rags in two projection. First day, and also we should monitoring and dynamics. What about the changes in common blood analysis in case of pneumonia? Firstly, it's leukocytosis, more than 12 giga per liter, shift to the left, toxic granularity of the neutrophils indicated a higher likelihood of bacterial infection. In case of bacterial pneumonia, leukopenia below 4 giga per liter or leukocytosis more than 25 giga per liter, lymphopenia less than 1 giga per liter, unfavorable prognosis signs in bacterial pneumonia. In case of virus pneumonia, leukopenia, lymphopenia typically in, for example, COVID-19 virus pneumonia. According blood biochemistry parameter, very important since is CRP. Previously, we think that significantly an increase of CRP associated only with bacterial pneumonia. Now, during a pandemic of COVID-19 infection, we confirm that also in case of virus pneumonia, CRP may be, for example, more than 250, 300, microgram per liter because it's a reflection infection. This why now we recognize of CRP as a marker of systemic inflammation. Also, in case of pneumonia, increase ferritin at the acute phase protein. And we also, in case of COVID-19 pneumonia, we monitoring this parameter, and this parameter have got a very important prognostic factor. Hospitalized patient with CAP recommended determine urea, creatinine, electrolytes, liver enzymes, bilirubin, glucose, albumin, procalcitonin. By the way, procalcitonin level more than 0.5 microgram per liter, it's indicated high probability of bacterial infection. That's why now, in case of, for example, if we meet patient and we suspect virus pneumonia, COVID-19 pneumonia, if increase procalcitonin level, we can suspect the presence of bacterial infection S2. It's mixed virus, bacteria, pneumonia. But if patient have got acute lung failure, for example, how can we make conclusion about acute lung failure? There are two, but in screening test, it's pulse oximetry. That's why if you detect pulse oximetry less than 90, such patients should investigate arterial blood gases. Firstly, it's partial pressure in arterial blood, oxygen, carbon dioxide, pH, bicarbonate, lactate, and other. And very important, since it's so-called coagulagram with determination of proton time, international normalization rate, thrombin times, partial thrombin times, and D-dimer. D-dimer reflects its destroy of fibrinogen, fibrin under the influence of activator of plasminogen of fibrinolytic system. It's a reflection of microthrombosis or microthrombosis, and we also should monitor this parameter and significantly increase this parameter more than 3 times more than normal level. It's indicating unfavorable prognosis for patient with, for example, COVID-19 pneumonia. Microbiological diagnostics, it's bacterioscopy, culture examination. We can obtain respiratory sample and also venous blood. Rapid test for example, influenza virus and infection, nucleic acid amplification test in PCR, SARS-CoV-2, and SARS-CoV-2 antigen. Pneumococcal and Legionella urinary antigen test, often and very easy, and can be performed after start of antibiotic therapy, by the way. And in this slide, you can see the gram positive. It's pneumococcus staining by gram staining, and gram negative, it's Haemophilus influenza. And the chest Rex, it's a very important test recommended for all patients with pneumonia. And the presence of infiltration, and can help you to confirm the diagnosis of pneumonia. Also, we can detect pleural effusion, sites of lung destruction, and this reflects to severity of this disease. By the way, if patient clinically have got not severe disease, if patient have got a pleural effusion, it's complication of pneumonia. Such patient should obviously be hospitalized because it's all complicated pneumonia must be patient must be hospitalized in inpatient setting. X-ray, for example, bacterial pneumonia, it's mostly local process with infiltrate, and in virus pneumonia we can hear a bilateral diffuse process with so-called ground glass infiltrates. Here it's bacterial pneumonia, local process with it's mostly it's CT scan, and you can see consolidation with a bronchogram. You can see the bronchis, and infiltrate pattern. It may be lobar, patchy, interstitial, cavitary, and large effusion. That's what such kind of infiltrate pattern we can detect due to X-ray examination. And COVID-19 pneumonia, it's the signs of ground glass opacity, it's multiple subpleural mostly, and in this cross section you can see the some kinds of consolidation. Also this infiltrates like here it's ground glass opacity, here consolidation, and some kinds of increase of reticular pattern. And the indication for higher resolution CT scan patient who have got a clinical signs of pneumonia, but in the X-ray no absent any infiltrates. And also X-ray study of the patient with suspected pneumonia revealed atypical signs, for example, atelectasis, pulmonary infarction, and other. And recurrent pneumonia, for example, in one side segment of the lung, we should obtain more detail from this side of lung, and we should recommend it strictly recommended patient perform high resolution CT scan. So additional laboratory instrumental investigation and ECG, but after 40 years of age, we strictly recommended patient make ECG, and we should pay attention QT interval, because a lot of antibiotics, for example, fluoroquinolones, and including respiratory quinolones, macrolide, can increase this QT interval. That's why patients have got, for example, 5 microsecond interval. Should avoid any drugs, any antibiotics which potentially can enlarge QT interval. Pulse oximetry, this method help you to detect acute lung failure and stage of acute lung failure. For example, if you saturation of oxygen from 90 to 94, it's first degree of acute lung failure. From 75% up to 89, it's second degree, and below 75%, it's third degree of acute lung failure. It's because we can't evaluate acute lung failure only by respiratory rate. Modify factor include this factor increase risk of infection with specific and antibiotic resistant pathogen, including age more than 65, and previously beta-lactam therapy, alcohol abuse, immune suppressive illness, including the therapy, intravenous corticosteroids, multiple medical comorbidities, exposure to a child in daycare center. And when we, after clinical examination and analysis of complaints, anamnesis, morbid and vita, clinical science, and X-ray investigation and other investigation, we confirm that patient have got a pneumonia. We should put 4 questions before you as a physician. First question, should the patient with pneumonia be treated in hospital or as outpatient? Second question, does the patient have a serious coexisting illness or is the patient elderly? And how severely ill is the patient at the time of the initial evaluation? But the very simply scales, it's for first patient visit in primary care, so-called CRB 65. What does it mean, this abbreviation, CRB 65? First, confusion. You can use abbreviated mental test score. If a patient have got score 8 or less, it's that's why it's patient have got a confusion. If patient have got a confusion, we put 1 point. For example, patient can be disorientation in person, place, or time. Second, R, respiratory rate. If patient have got a respiratory rate more than 30 per minute, it's also 1 point. If less, 0 point. Blood pressure. Diminished diastolic blood pressure less than 60 millimeter mercury, systolic less than 90 millimeter mercury. It's also 1 point, according to this score. And 65 is age. If patient have got a 65 years or more, it's also 1 point. We summarize this point, and in general, common point 0, low risk of mortality. Such patient can be treated at outpatient setting. From 1 to 2, it's intermediate risk. Mortality up to 10. And from 3 to 4, higher risk. And mortality, in case of initial evaluation, in case of outpatient, because per patient, we also can use so-called curve 65. It's all point like a CRB 65, but it's necessary to know the blood nitrogen. If more than 7 millimole per liter, it's 1 point. In a case, for example, 0, and the patient can be treated in outpatient setting, and service 2 short hospitalization, medical, and 6 from 4 to 5. Its patient should be intensive QA unit. Intensive QA unit. By the way, this score should be aided by pulse oximetry because it's for example, if patient have got a drop of blood pressure, it means in case of pneumonia, it's reflect to the present a complicated that pneumonia complicated by septic shock. But for example, patient may have no confusion, respiratory rate less than 30 and age less than 65, but it's 1 point. But such patient should be hospitalized in intensive care unit. And for example, respiratory rate more than 30, but all points are 0. It also patients should be hospitalized. And often you, in a case inpatient setting, you can use a pneumonia severity index, include age, sex, and comorbidity, vital signs, including respiratory rate, systolic blood pressure, temperature, tachycardia, respiratory rate, mental confusion, lab abnormalities here, and calculate and summarize point less than 51. It's patient has got a less risk of mortality. If patient have, for example, 5 plus more than 130 point, it's patient have got a higher risk of mortality. What about severity of COVID-19 pneumonia? According to the national recommendation of Ministry of Health of Russia Federation, mild illness can be treated on outpatient setting. Body temperature below 68.5 degrees of Celsius, cough, weakness, so that's why it's the signs of affection of mostly and only upper respiratory tract. No criteria for moderate and severe course. In case of moderate illness, fever about 68.5 degrees of Celsius, respiratory rate more than 22 per minute, shortness of breath on exertion, pneumonia confirmed by the CT scan of the lung, and saturation of oxygen from 94 to 95, less than 95, but more equal 94. On room air at sea level, and serum CRP, C-reactive protein more than 10 milligram per liter. It's moderate illness, and such patient in most should be hospitalized in infection department. And severe illness, and respiratory rate more than 30 per minute, drop of oxygen saturation less or 93% on room air at sea level, and ratio between the pressure of oxygen in the arterial blood and level of oxygen it's exhale air less or equal to 300 millimeter mercury. Progression of changes in the lung according to X-ray, CT scan or ultrasound, more than 50%. It's a so-called CT scan degree 2 or 3 after 24-48 hours. Decrease of consciousness, agitation, unstable hemodynamics, systolic blood pressure less than 90 millimeter mercury, and diastolic blood pressure less than 60 millimeter mercury, urine output less than 20 millimeter hours, arterial blood lactase more than 2 millimeter per liter, and Quisofa scales more than 2 points. And critical illness at present, acute respiratory failure with the need for respiratory support, invasive ventilation, septic shock, multiple organ failure, changes in the lung of CT X-ray, typical for critical virus embolism, so-called, it's practically, what does it mean, CT4? It's a percent of lesion of the lung. It's from the up to 25% is CT1, CT scan 1. From 25 to 50, it's CT2. From 50 to 75 is CT3, and up to 75 is CT4. And the present acute respiratory distress syndrome with its acute respiratory failure plus multi-organ failure. Risk group 65 years of old, pregnancy, comorbidities. And in among comorbidities is firstly is cardiovascular disease, chronic lung disease, sickle cell disease, diabetes, cancer, obesity, chronic kidney disease, being pregnant, being cigarette smoker, being a recipient of transplant of immunosuppressive therapy. Tool optimized for community acquired pneumonia outcomes, and patient we obviously in the first contact should determine the oxygen saturation through the pulse oximetry, but availability of urgently radiography, time to take a sample of arterial blood if patient have a saturation less than 90%. This determine of arterial blood pressure of oxygen should be less than 3 hours. Taking blood sample for bacteriological examination before the first doses of antibiotic. Time to first dose antibiotic, it's less than 4 hours. Antimicrobial therapy is accordance with the existing guidelines, using the available forecast assessment scale for all hospitalized patients with CAP, and estimation of prevalence vaccination in patients at risk. Complication of pneumonia, including the formation complicated by parapneumonic pleurisy, empyema of the pleura, and it's purulent inflammation of the pleura, lung sepsis, acute respiratory distress syndrome, acute respiratory failure, septic shock, multi-organ failure, atelectasis, secondary bacteremia with hematogenous foci of dissemination lead to formation of abscess in the brain, liver, skin, soft tissue, endocarditis, pericarditis, myocarditis. And what about treatment? We start with treatment of virus pneumonia. It's first recommended antivirals drugs, including favipiravir, remdesivir, aminofenavir, hydrochloroquine, and interferon alpha in anti-COVID plasma. And treatment pneumonia in hospital. You should know that we should hospitalize patient with start of cytokine storms. That's why the main direction of anti-inflammatory treatment should be direct to block these pro-inflammatory cytokines. In the mild course, we can recommend it and use so-called Janus kinase inhibitor, tofacitinib or baricitinib, interleukin 17 inhibitor, nicotibab, and interleukin 6 inhibitor, very important, olokizumab, levilimab, and for example, severe case, we can strictly recommend it tocilizumab, sarilumab, but more effective among these interleukin 6, it's tocilizumab. And glucocorticosteroids are the first choice drugs for all hospitalized patients. And but according recommendation, national recommendation of health ministry, we can't recommend it. We should not recommend it patient corticosteroids in outpatient setting. Antithrombotic therapy in hospital, we use low molecular weight heparin and unfractionated heparin, oral anticoagulants, including rivaroxaban. Symptomatic treatment, including paracetamol, non-steroid anti-inflammatory drugs, in case of fever, mucolytics, bronchodilators, and antibiotic therapy only according to indication. In this slide, you can see the recommendation of National Institution of the Health, and last update in April. For patient who have a high risk of disease progression, in case of outpatient condition, not hospitalized, recommendation and anti-SARS-CoV-2 monoclonal antibody in this level. Balmanivimab plus ezavimab. And second combination recommended by this organization, institution, casirivimab plus imdevimab. It's a monoclonal antibody against spike protein of this SARS-CoV-2 virus infection. And in a case of, by the way, for in a mild course patient no need to supplemental oxygen. For patients which have got a saturation equal or less than 93%, we should recommend it supplemental oxygen. And firstly, it's maybe a low flow device start in prone position. And each 2 hours we should stop oxygen therapy and check saturation with oxygen therapy and without oxygen therapy. And patient, if have got a drop of oxygen saturation less than 88%, we should increase and this. We should recommend patient higher flow devices, oxygen through the mask. And for example, the higher flow, it's approximately from 7 to 20 liter per minute. And if in prone position, patient have got a drop of oxygen saturation, we also should switch our oxygen therapy for non-invasive ventilation. And then progression of disease, maybe patients should need mechanical ventilation, and also two patients in Crimea obtained now treatment using extracorporeal membrane oxygenation. If mechanical ventilation not support the normal saturation and normal pressure of oxygen. And when we use bronchial alveolar lavage and we can't detect the alveolar macrophage, we also can detect dendritic cells, debris, I miss it's we can't detect any living alveolar macrophage. It's an indication for lung transplantation. And for example, in lung transplantation, Austria, for example, a special center which uses emergency lung transplantation. Unfortunately, we have no such experience about this lung transplantation. This is why it's concerning oxygen therapy. We start with supplement, using this low flow devices, oxygen concentrator up to 7 liter per minute, and then higher flow devices and non-invasive ventilation, mechanical ventilation, and ECMO. And what about treatment patient recommended of National Institution of the Health? It's, for example, for hospitalized patient, it's remdesivir plus dexamethasone. And also, but for patient on non-invasive ventilation, we should add the tocilizumab. We talked about this, not tocilizumab. It's interleukin 6 inhibitor, and for tocilizumab also recommended for all patients with severe course. But if we are talking about bacterial pneumonia, it's we should think about antibiotic therapy. But so we should check the structure, antibiotic resistance. For example, because it's a different country, we have got a different antibiotic resistance. For example, in our country, we have a higher antibiotic resistance for sulfanilamide and tetracycline antibiotics. But for example, in India or United States, first choice it's doxycycline. It's tetracycline antibiotic because antibiotic resistance is not higher comparing with our country. Epidemiological characteristics: age, comorbidities, travel, safety profiles. We should analyze it, possibly adverse events, a drug interaction, and pharmacokinetics and cost. Risk factor for detecting pneumococcus resistant to penicillin resistant pneumococcus. It's age over 65, recent using of beta lactams, antibiotic therapy, serious chronic comorbidities, alcoholic abuse, immunodeficiency, close contact with children attending preschool institution. When we should start therapy? No later than 4 hours from the time of the diagnosis. And from the onset of symptoms, it's approximately 48 hours. Late diagnosis, 72 hours after the onset of the symptoms. Criteria for effectiveness of antibiotic therapy. It's necessary to take throughout the 48 hours from the moment of the beginning of the treatment. That's why after 48 hours, we should analyze effectiveness of our antibiotic therapy. What about criteria of effectiveness of antibiotic therapy? It's diminished body temperature less than 37.5 degrees of Celsius, reduction of intoxication, reduction of manifestation of respiratory insufficiency, respiratory rate less than 20 per minute, the absence of purulent sputum. Duration of antibiotic therapy. In mild course of CAP, it's from 7 to 10 days. Severe, from 40 days, and but it's not less than 40 days. Including mycoplasma, chlamydia, also 14 days. Criteria for cancellation of antibiotic therapy is normalization of body temperature for 3 to 5 days. But I told that we can treat patients with not severe community-acquired pneumonia in outpatient condition. We should separate patients for two clinical groups for treatment. First group is not severe CAP, aged up to 60 years, without comorbidities, not taking antibiotics, last 3 months, more than 2 days, and other risk factors. The most common pathogen is pneumococcus, mycoplasma pneumonia, chlamydia, Haemophilus influenza. We can recommend this patient amoxicillin orally and secondary macrolide. It's according to recommendation of National Respiratory Society. And second group, not severe community-acquired pneumonia in patient less than 60 years of old, with patient more than 60 years of or older, with comorbidities, taken for the last 3 months of antibiotic therapy, and having other risk factors. This is same, but Staphylococcus aureus maybe, Enterobacteria also, but in few cases. But we should prescribe enzyme defenders, amoxicillin, clavulanic acid, and alternative treatment, respiratory fluoroquinolones, levofloxacin, moxifloxacin, and or cefditoren. It's third generation of cephalosporin orally. For example, amoxicillin 100 mg every 20 hours. If we are talking about enzyme defended amoxicillin, it's an amoxicillin clavulanic acid. And for my recommendation, you should use such combination when more amoxicillin and less daily clavulanic acids. For example, much better if you choose amoxicillin 875 milligram, pardon, and clavulanic acid 125 mg every 20 hours, 2 times a day. Because if other combination 3 times per day, patient obtained more clavulanic acid. And this trade name, moxiclav, augmentin, azithromycin. By the way, now during the pandemic of COVID-19 infection, a lot of microlights use patient, and previously in some country microlight resistant reached to 30% and more. But now the recommendation for microlights, for my opinion, under the big question. By the way, according to the existing recommendation of Russia and Respiratory Society, azithromycin 500 microgram once a day during 5 days, clarithromycin 500 micrograms 2 times per day, 7 days, and respiratory fluoroquinolones, moxifloxacin 400 micrograms for 1 times a day for 10 days, and levofloxacin 500 micrograms 1 times a day for 10 days. Oral cephalosporin, including I told cefditoren, 400 micrograms every 20 hours. But in case of in this slide mistake for inpatient community-acquired pneumonia for inpatient, but should be begin with parental dosage forms. In severe case, intravenously administration. In the clinical stabilization progress, patient may be switched to oral therapy. The framework works on the concept of the step therapy. The step therapy for antibiotic therapy, including, for example, start with intravenous intramuscular administration of antibiotics, then switch to oral, for example, the same antibiotics. If you reach effect, for example, we can start with levofloxacin intravenously, then in case of effectiveness of antibiotic, we switch orally, levofloxacin orally. Also, in case of inpatient patient, not severe community-acquired pneumonia, also 2 groups, including first group and second groups the same. For example, not severe, up to 60 years of old, without comorbidities, no history of antibiotic therapy during 3 months, more than 2 days, no risk factor. Ampicillin or amoxicillin clavulanate or sulbactam. In this case, its alternative is enzyme dependence, which you should know that clavulanate or sulbactam or tazobactam prevent beta-lactams from destroy of broad spectrum beta-lactamase. Or respiratory fluoroquinolones, for example, intramuscular, intravenous. Then we can switch orally. Second group, we should start with beta-lactamase and aminopenicillin with beta-lactamase inhibitor, amoxicillin clavulanate, sulbactam, third generation of cephalosporins, cefotaxime, ceftriaxone, respiratory fluoroquinolones, and carbapenems, eterpanem. Patient with risk factor of Pseudomonas aeruginosa should use antibiotics which have got effectiveness against Pseudomonas aeruginosa. So, for example, in case of severe course of pneumonia, but patient without risk factor of Pseudomonas aeruginosa can use antibiotics which have no effect against Pseudomonas aeruginosa, including third generation of cephalosporin, ceftriaxone, amoxicillin, ковалентic acid, macrolides, but patient with risk factor should use antibiotics which have maybe two antibiotics have got a effectiveness against Pseudomonas aeruginosa, including piperacillin tazobactam, fourth generation of cephalosporin, cefepime, carbapenem, meropenem, imipenem, and plus, for example, ciprofloxacin is the third generation of fluoroquinolones, but these drugs have got highest activity against Pseudomonas aeruginosa and respiratory fluoroquinolones. Levofloxacin, you can recommend it as too. So the main cause of death in patients with severe community-acquired pneumonia, including refractory hypoxemia, septic shock, multiple organ failure. The main factor associated with poor prognosis in patients with severe community pneumonia, it's age, mechanical ventilation, bilateral localization of pneumonia, sepsis, and infection with Pseudomonas aeruginosa, a late appear for medical care. Complication, hypotension and septic shock, pleural effusion, empyema, lung sepsis, multiple metastasis of Staphylococcus aureus septicemia, multiple pyemic abscesses. What about prevention? First is smoking cessation, health style of life, and treatment of comorbidity and vaccination against influenza, against SARS-CoV-2 infection, and pneumococcus, anti-pneumococcal vaccination. You should know the two types of anti-pneumococcal vaccine. You should recommend this vaccine. But I would like, I forgotten that's what indication for antibiotic therapy for this virus, COVID-19 pneumonia. Firstly, for example, is according the recommendation of Health Minister of Russia Federation, temporary recommendation, it's firstly such signs. First, it's purulent sputum and leukocytosis if patient have no obtained systemic corticosteroids before it shift to the left. And very important, procalcitonin level. Procalcitonin more than 0.5 is higher probability for bacterial pneumonia. That's why if we analyze this factor, we can add to therapy of COVID-19 pneumonia antibiotics, but it's not for all patients. It's only strictly indication because in case of virus pneumonia, antibiotics can't destroy biofilms of normal flora, which protect against respiratory infection, respiratory bacteria. That's why you should prescribe antibiotics for treatment COVID-19 pneumonia. For such recommendation, that's all that I would like to discuss today. I thank you so much for your attention, and I wish you be healthy, and I wish you good knowledge in a very dramatic field of modern medicine, like a new field of pneumonia, acute the respiratory infection caused by bacteria or viruses. Thank you very much. Goodbye.